We would like to welcome you now to the Endoscopy Now virtual education series. This series is meant to be educational, obviously, and the topics that are chosen are innovative and ones that I think look at sort of the leading edge of endoscopy. And tonight we're going to be talking about advances in pancreatic treatments and specifically looking at RFA ablation of pancreatic masses. I guess first of all, I should introduce myself. Gregory Haber. I am Chief of Endoscopy at the NYU Langone Health System. I'm a professor of medicine there. And I have been involved from some of the early stages of the RFA technology, and I'm very honored and pleased to be able to moderate this session. I would like to remind you that we'll have 3 different presentations by our speakers with a panel discussion, but your questions will be addressed at the end of the talk. So there is a question and answer icon at the bottom of your screen. So as questions come up, please enter those into that question and answer box, and we'll do our best to address most of the questions. I would like to acknowledge Tai Wung Medical USA, who have sponsored this. They've been very generous in allowing us to come together and to put together this talk for the Endoscopy Now audience. Our speakers, Tomas Ganda is an associate professor of medicine at NYU and has come to be the chief at Tisch Hospital of our endoscopy unit there. Tomas has had a very productive career, especially within the realm of pancreatic cancer and pancreatic research. And so it's particularly appropriate that he'll be addressing us on RFA ablation of pancreatic neoplasm. He is now an associate professor at the NYU Grossman School of Medicine. Welcome, Tomas. So this is the East Coast cohort with Tomas and I, and now we'll move to University of Texas Health. We have Nirav Tassani, who's the chief at the Center for Interventional Endoscopy at the University of Texas Health, and his colleague, Curtis Ray, who did his fellowship at MD Anderson, Texas, and stayed at UT Health as an associate professor of surgery. So our speakers have worked very hard to make this a productive session for everybody, and I will thank them in advance of their talks. I would like to welcome all of you, of course, and this is a slide to acknowledge Tai Wung, who have, as I said before, generously sponsored this session. So now some disclosures, which we'll throw up very quickly. And now we'll move on to Dr. Ganda, who will present on EUS-guided RFA of pancreatic neuroendocrine tumors. So I'll turn this over to Tomas. We'll start actually with a video that we put together last week specifically for the meeting today.
Good afternoon, and thank you for joining us today for this very interesting case. I'm going to start by introducing our team. Next to me is, of course, Dr. Greg Haber.
Hello, everyone. Welcome. We're all very excited to see this case. And then
we have a whole team behind us.
Lisa and Rachel are at the back there and helping out, as always.
And we have Ed from anesthesia. We have the patient under general anesthesia for this procedure, which I think is somewhat helpful, potentially.
Yeah.
So I'm going to just tell you briefly about the case. This is a 55-year-old man who actually had a reasonably incidentally found lesion identified in the pancreas several years ago, actually, and it was predominantly thought to be a cystic lesion, was surveyed as a small IPMN and grew from about 1 centimeter to 2.5 centimeters, and when it was 2.5 centimeters, it was sent for a biopsy. And somewhat surprisingly, on the EUS at the time of the biopsy, it was actually predominantly more of a solid lesion, and ultimately the biopsy or the fine needle aspiration showed neuroendocrine cells. A fine needle biopsy showed a grade 1 neuroendocrine tumor with a low Ki-67 index. And we've had a long discussion with him. It's a little bit over 2 centimeter lesion, which, according to most guidelines, is kind of right on the cusp of observation versus therapy, potentially resection. And given the availability of potentially non-surgical techniques, we have elected to resect this. Elected to ablate this.
Yeah.
So this was now a year and a half ago. He underwent a first ablation, and at the time this was again a 2.3 centimeter lesion. It was actually one of the earliest cases that I have personally done, but perhaps we have all done. He had 2 ablations. And one of the discussions we've had is, partly how to target treatment. And as you can see, there's a little bit of heterogeneity in there. There's some dark areas which we thought prior to in our prior discussion, and maybe areas of necrosis. The other so that would be something that we would consider take into consideration in targeting treatment.
And the only other thing we discussed, Thomas, was the injury to the pancreatic duct with the radiofrequency ablation. So, the risk of pancreatitis, of course, or especially pancreatic duct stricture. So it is good to try to identify the pancreatic duct, and you do like to have, about a 5 millimeter clearance. If you don't have it, then there's the option of pre-RFA to place a pancreatic stent in the duct, and obviously it depends where the lesion is vis-a-vis the duct. If it's in the neck, body or tail, I think if it's in the tail, we're not going to bother doing that.
Right. So I think in this case, on the cross-sectional imaging, there was a reasonable distance. It's a little bit hard to get a perfect view of the pancreatic duct. Here, I think it's there now. Yeah. And as I follow it, it's kind of curses around, and you kind of lose it a little bit. I think I will probably try to avoid coming very close to the lower edge of the lesion, which may be the closest point to the pancreatic duct.
Right.
And similarly, you want some distance from the vascular structures, or at least want to avoid lesions that are right on top of the blood vessels. And it seems like there is, at least the splenic vessels here are at a reasonable distance.
Right. And of course, you have the experience of having done this once without any problem related to the pancreas. So at least
hopefully that gives some comfort as well.
Helps us a little bit, right.
So we were actually going to use contrast to further identify our potentially for 2 reasons, which is something that that has been described in the literature. So in this case, as a repeat treatment, it may be a way to target areas of ablation, especially if we identify parts of the lesion that are more contrast enhanced versus others. And then in some experts have also recommended using contrast after treatment to really look at sort of where to target potentially subsequent or residual treatment areas after first or second ablation. So one of the first decisions is really to decide what size needle one uses for the ablation. So there are 3 different sizes. Could you switch to the
lights up there, please, James? I think if you just focus on the cheat sheet here, we'll get our lighting a little bit. We'll even go in closer if we could. Could you, as close as you can get it, Roger? Roger's doing an amazing job with remote camera work.
Yeah.
Yeah, those little orange lollipops. Okay. So 3 size RFA tips, the 5, 7, and 10. And you can see here the suggested wattage and time of ablation, and then the zone of ablation. So for the 5 millimeter tip, you have a 5.6 by 6.9 millimeter ablation zone. And then if you're up to the 10, you see the 8.6 by 14. So you get that little bit of a oblong, if you like, effect from the probe tip. And maybe Tomas could comment. You know, we were discussing here you have recommended wattage and time. And the question I had, and I don't think we have an answer, is are we better off with maximum wattage of 50 watts with 2 seconds versus, let's say, 10 watts with 10 seconds? I don't know, have an answer. Tomas, do you want to speculate?
Don't have a very good answer either, but I think the relatively low wattage for a longer period of time is thought to be safer, especially since you're relatively close to critical structures. I mean, you're sort of in the pancreas, near the pancreatic duct. I think the very high wattage, even for a short period of time, may be associated with some of the higher risk of injury. And I think in some of the studies that actually may have been speculated, I wouldn't say it was shown. I think one of the advantages of this system, which hopefully we'll be able to show, is that in addition to sort of this built-in control of the amount of energy that is being delivered, we also have the ability under endoscopic ultrasound to use some secondary signs that we will see to sort of assess when too much tissue destruction is being accomplished or when we're going outside the boundaries of the lesion.
Right. So there is no automatic shut-off in terms of time and wattage, but if you do reach the 800 ohms resistance, in other words, if the tissue is totally desiccated, it's not conducting anything at all, the machine shuts off automatically. But that only at that point when you get that degree of resistance. All right. We're just going to...
I think in true balance fashion, we're going to choose the in-between size. I think 10 millimeters for a 10 millimeter by 15 millimeter lesion is a bit too much. And I think 5 millimeters would be a little bit too little. And I think Dr. Haber is showing the device now. So probably the most unique feature of this is is the fact that this is a 19-gauge needle with a cooling mechanism in it. So it's the tip, I guess, the white part.
If we could go into the, that's it, Roger. And there we go. That's great. Perfect. Amazing, yeah.
So that's the ablation zone. And then if you can show the handle for a moment, you can see there is two kind of quote-unquote catheters coming in. And one of them is the energy or the connected to the electricity. The other is a cooling channel. So what it does is, as the ablation is happening and as the tissue is heating up, it actually cools simultaneously the needle, which allows a larger zone of ablation without sort of the charring impeding the ablation.
Yeah, so you see the coloration, that gold coloration is the cooled part of the needle. And then, of course, we have the 7 millimeter tip for the actual delivery of energy.
So I can see now the tip of my needle kind of on the left periphery, which is a little bit where I want it to go. Of the lesion, maybe a little bit more peripheral.
Let me just show this if I can. I'll help with the cursor again if I may.
Yeah.
Just, okay. So here's the tip of the needle. Where are you, Ken?
We're actually...
sorry, I haven't been following.
Yeah, no, right there.
Oh, sorry, there you are. Yeah, there it is.
Yeah,
yeah, very nice.
So we were going to try to focus on the left side, so this is about as left as I think we can go, or proximal. And I think we're ready for the first ablation. We're just waiting for the needle to prime. We're good.
Okay, go. Oh, yeah. Yep. Okay, good.
Okay.
So we're ready?
So I think we're ready. So we're going to...
Power's going to go on?
Yep. Somebody's going to watch the time. So you can watch
1,
on the
2,
US image. You're
3,
beginning to see... There you go. You're beginning
5.
to see the white bubbles. It's still quite within the lesion. So I'm kind of letting it go.
We're 11 seconds.
It's kind of approaching the edge of the lesion.
We're now 21.
Perfect. Okay, so let's stop.
So we've stopped at about 23 seconds. So that was something that, Tomas, you were judging according to the
Yeah, so I was,
snowstorm, if you like, or the
I'm going to come out
change
and
in the,
actually
echogenicity.
try to identify a slightly different area. So you can see the echogenicity kind of remain. I'm going to...
Over here.
Yep.
So there's the needle movement up here, now being moved down. Beautiful, right in here.
Try to go a tiny bit deeper. Good, we're in the lesion there.
All right, are you ready?
I think we're ready. Go
okay,
ahead.
Power on, 20 watts, and now we're counting. 5 seconds.
And there it is, yeah. Starting to see, we're still like within the lesion.
12 seconds, 15, 20 seconds.
I'm gonna let it, so the impedance is still not rising super high, but I think now the white bubbles are at the surface, so we're gonna stop. Yeah, and now actually the impedance just started to rise. So I think it was sort of a nice,
nice duration of ablation.
yeah.
The DOA, as we call it.
The DOA. All right, so let's see if we can, so we've got quite a bit of this white fuzz or white snowflakes in the lesion.
Yeah, that's a nice, there's a good view of it, isn't it?
Yeah, we've actually done 2 treatments.
So do you think, no, I'm just sort of thinking about that, is that disruption of cells, obviously, but is that sort of a vaporization rather than liquid, and water would show up as sort of
I would assume it is something to do with vaporization, and it may be just artifact, and I'm not sure that anybody has sorted out whether it truly correlates with like sort of ablation, or necrosis. I'm wondering whether this would be a time, or maybe we would do one more treatment, then contrast again. Yeah.
If we have the contrast ready, that would be great. Okay. I mean, you can always, I guess, see how quickly the white cloud appears.
Right. We can just do a short ablation
earlier
on a third one.
So the needle's coming from up here. There it is there. And we're going a little bit more to the right. The original punctures were a little bit more to the left. Very nice. There we go. Looks like it's in good position there, Tomas.
Yep. I think
okay, so again, we'll try to get a hypochoric appearance so we can appreciate the bubbles. Okay,
yeah.
There we go.
So let's try there.
I think we're ready to go. We now have the RFA going. We're at 5 seconds. I guess I should tell the impedance.
Yep, there are the white bubbles kind of starting to appear. Good.
This is around 130.
Good. And I think I would stop. We're at 19
20 seconds. That should be.
Yeah.
And we're on 120. Okay, that's the end of that. Very nice.
All right.
Okay.
So I think 3 treatments is probably reasonable.
Right.
Would you do another?
No, I don't think so. He's with his age and he's asymptomatic, and the worst case scenario is you'll come back in 6 months. It's not.
So most of the literature have shown really decent responses, 80 to 100% complete resolution with 1 to 2 treatments, and the average number of ablations were well under 5 in most of these sub 2 centimeter lesions. So I think at 2 centimeters we are we're at a good place. I usually just check, although I don't know how useful this is, if there's any strange bleeding or anything going on the
Right.
post ablation treatment.
Yeah.
And I think
If anything, it's less hypoechoic. It's more heterogeneous, I would say, than it was pre-treatment.
yes,
Which I'm assuming is disruption of cells, maybe a little bit of bleeding in the lesion, maybe, I don't know.
maybe. Yeah, I particularly look sort of like in the liver biopsies at like blood vessels or any sign of bleeding kind of between the transducer or around the lesion. Not sure I've ever really seen it, or I'm not sure what I would do if I saw it, to be honest, but it just gives some comfort that we're not seeing that.
Yeah. Excellent.
All right.
Well, Tomas, you've made it look very simple, very straightforward. Nice having that lesion.
Yeah,
right
so this is definitely, yes, it's the perfect lesion to do. Not that I think the needle is easy to handle, but I think the body tail of the pancreas is really wonderful. So so thank you.
Okay, high five.
High five.
High five.
All right. Thank you, everyone. Thank you for joining us.
All right, I think we're ready to move on, Tomas, with the more didactic presentation.
Sure, thank you. Thanks, Greg. Good evening, everyone. So the next few slides we'll just go through very quickly a little bit of the published literature and how it relates to the case that we just saw. We have the next slide. Okay, so just some of these things were in the video and maybe some of them were not clear, but this is just kind of planning considerations, in particular, especially for treating neuroendocrine tumors. So sort of the anatomic considerations that I think we always pay attention to is, again, proximity of the pancreatic duct. And I think in general, 3 to 4 millimeter distance is kind of recommended. There are some cases where a pre-ablation ERCP with a pancreatic duct stent was placed if there was real concern of the lesion being very close to the pancreatic duct. And similarly, some cushion between the lesion and larger blood vessels, or at least the ablation area and larger blood vessels, has been recommended. We saw in this video a little bit of the use of contrast-enhanced EUS, which I think is a very nice way to either target specific areas of the tumor, and you can see on the top figure there, or top image there, how the needle is really targeting an area that was previously enhancing on contrast, and it is also a very nice way, which is shown on the bottom, of how you can sort of appreciate treatment response when an enhancing area of the tumor, as shown on the bottom left, goes to a kind of non-enhancing area on the bottom right image. And then finally, a couple of other considerations. So some have advocated using or performing aspiration when you're dealing with a predominantly or largely cystic tumor, as a way to reduce some of the complications that have been rarely seen in these cases. And then the last consideration is, as we saw in the video, is really the decision about needle size or needle size choice, which as we demonstrated, there's a choice of 3 needles really determined by tumor size. Next slide, please. So this is, so I just, in the next 3 or 4 slides, we'll just summarize the published data on different tumor types. The vast majority of the data is in neuroendocrine tumors, and there's now about 4 or 5 case series that have been published. The one on the left is probably the first one, which just shows a significant reduction in size of tumors after 1 radiofrequency ablation. The top table next to it is I think relevant to show that clearly there's a significant response seen in the majority of these tumors, but the recognition of this response is a little bit higher at 12 months. And I think this speaks to the fact that if you image these patients relatively close to or soon after the ablation, you may not actually appreciate a significant either decrease in the size or a significant increase in the area of non-enhancing tumor. And then the bottom table just summarizes the 3 larger series, which have all been in functional and non-functional neuroendocrine tumors with significant follow-up times. The tumor sizes were on the 10 to 20 millimeter side generally, although they have included a few larger tumors, and complete response rates after, again, 1 to 2 treatments have been somewhere between 80 and in one series 100%. Next slide, please. So this is just to show again this point about how the CT imaging is very helpful in demonstrating response, but you should expect that if you're going to image the lesions relatively soon, there will not be as much of a size decrease seen at 2-3 months, and it's really recommended that unless there's other clinical reasons, that you wait somewhere between 6 and 9 months with imaging where you can see sort of the maximal response. I'm not sure there's real advice to be given on whether to use contrast CT, MRI, or even a dotatate scan for dotatate active neuroendocrine tumors, but those are the 3 options. Next slide, please. So this is a very small amount of data that has been published in cystic neoplasms. This is an interesting area, and I think it's valuable to note that, again, the procedure has been safe in the majority of these lesions, with a significant response in 60-70% of the cysts. Again, this is fairly early data. This is what's out there at the moment. Next slide, please. So this is a very nice series in a disease that I think most of us would potentially not think of treating in most clinical scenarios, but certainly serous cystadenomas can cause symptoms or can enlarge at an alarming rate, which leads to potentially surgical resection in a not small percentage of these cases. And this Korean group, who's really pioneered this technology, has shown that when treating these lesions, they're able to achieve a very significant size reduction in these serous cystadenomas. Again, this is a select population. These are large tumors. So one difference here is that the size of these tumors at start is much larger than in the previous treatments, and there's significant size reduction observed without significant side effects. Next slide, please. And then this is the experience which I think Dr. Tassani will talk more about in pancreatic cancers, the published experience, which again I think is fairly early days in how to incorporate this technology in the treatment of pancreatic adenocarcinomas. But at least in this series of a handful of patients, significant reductions in primary tumors were seen. There's a wide variety of therapies that are given simultaneously to radiofrequency ablation in these cases, but notably no significant adverse events were noted, and significant reduction in tumor sizes were observed in nearly all of these cases. And next slide, please. And in some ways, this is the most important slide. So this is summarizing all of these clinical studies and the side effects or adverse events that have been noted, which are fairly mild. So for the first 2 columns, or second and third column on the left, is the neuroendocrine tumors, showing the number of cases included, and the side effects, which are predominantly somewhere between 5 to 10% of mild pancreatitis. The majority of these are really just chemical pancreatitis with very mild symptoms. Notably, in the larger recent series by Barthé and colleagues, there were 2 cases of infected necroses, and these were the cases where cystic lesions were ablated, and their strategy after these 2 cases was to aspirate the cysts, and did not encounter further cases of infections after adopting that practice. Similarly, in cystic lesions, relatively very few side effects in a small number of cases, and similarly in pancreatic cancer. And I think that's all. Yes, and I think that's all. So I think we will go back to the cases.
So I think we do have time for a panel discussion. A little bit of time here. Can I ask perhaps our other speakers any questions that come to mind? If your mics are turned on, Curtis, maybe you could turn your mic on.
Yeah. So Thomas, great case, great presentation. many of us do not have luxury of doing a contrast enhanced EUS. So any recommendation that if you do not have it, how you monitor treatment response and which areas to target just by using beam mode imaging?
Yes, so I'm also just starting to use contrast, and I think it's something that's we're going to see spread a little bit wider in terms of use. But I think you can use some of the sort of EUS appearance of the tumor. So in the case we showed, you could kind of appreciate some of the very dark areas of the tumor, which we typically think of as the more necrotic areas of the tumor, as opposed to the more vascular parts. I think even maybe using Doppler in neuroendocrine tumors can help you with these are very vascular tumors, so so sort of diffuse Doppler signal can be a good target. I really think that in the initial treatment, it's quite a bit less important to use this. It's just a very nice tool to be able to sort of tailor when you stop potentially after a few ablations. I don't think it's critical. It's a helpful adjunct.
Right. No, I think you're right about that. I mean, Doppler certainly is the surrogate marker for contrast ultrasound, and it could be used. And I guess we should mention that we use antibiotic prophylaxis as well, for the procedure. And Tomas, what would be your typical follow-up? When would you? I mean, you mentioned that it's better to wait. Would you wait 6 months? I mean, what in practice, what would you recommend, for instance, for this patient?
So I think this patient is someone with a quote unquote just less than 2 centimeter neuroendocrine tumor. So I think I would I usually try to stick to the sort of surveillance intervals that I would recommend if I didn't treat the lesion, which would be in 12 months potentially for this. I think, as I alluded to in the presentation, I kind of learned my lesson that if you image too soon, you may be disappointed with the result, and ultimately these are, especially the neuroendocrine and the cystic lesions are ultimately relatively low risk lesions. I think have the luxury of waiting, potentially 6 to 12 months. That's usually the interval when I will look again.
Yeah. Lastly, Tomas, in that summary of several different series where the complete response was quoted at somewhere around 85%, around that margin, around that level. Complete response is defined by what? 50% reduction in volume? What defines complete response for this treatment?
So complete response in most of these series was defined as absence of an enhancing tumor and essentially resolution, or at least 80%. I think it was 80% size reduction, but definitely loss of enhancement on contrast imaging.
Okay, good. Which is very helpful. I think we're ready to move on, and we're pleased to have Nirav present his cases, which will be done with the video. So again, just please write your question and answers or send your question and answers with the icon at the bottom of your screen.
Hello everyone, I'm Dr. Nirav Prasami. I'm going to discuss our early experience with EUS RFA for borderline resectable and locally advanced pancreatic cancer. These are my disclosures. So let's spend a few minutes reviewing current staging and treatment options for pancreatic cancer. As we all know, for pancreatic cancer, survival is truly dependent on ability to resect tumor with negative margin. Based on its anatomical location, pancreas is in very close proximity with various important vessels. When we stage pancreatic cancer, it is very important to understand relation of cancer to various important vessels such as celiac axis, superior mesenteric artery, common hepatic artery, portal vein, superior mesenteric vein, and inferior vena cava. Based on arterial and venous involvement, we can categorize pancreatic cancer into resectable, borderline resectable, locally advanced, or unresectable cancer. So the big clinical question is, For borderline resectable and locally advanced pancreatic cancer, can you use EUS RFA with neoadjuvant therapy, and will it reduce tumor size? Will it allow R0 resection, and will it improve overall survival? We do not know answer to these questions yet, but there is some evidence that EUS RFA may be beneficial. This is our unpublished data that we will be presenting at DTW this year. About 3.5 years ago, we enrolled 10 patients with unresectable pancreatic cancer, and they underwent EUS RFA in addition to adjuvant chemotherapy. Patients underwent 1 to 4 sessions of EUS RFA, and we had at least 3-year follow-up for all patients since last RFA treatment. Our survival data using Kaplan-Meier survival analysis showed median survival of 18 months with 95% confidence interval of 10 to 46 months. This was much higher than expected survival for unresectable pancreatic cancer based on CR data, which is about 9 to 12 months. It is important to note that our study was not randomized and we had no control group. Our primary endpoint was procedure safety and not survival. Now, if you look at this data in more detail, 2 patients are still alive with survival of 41 months and 61 months respectively. Now, let's review patient number 8 in more detail. This patient was a 65-year-old man with 3 centimeter size pancreatic head cancer. Cancer involved celiac axis, superior mesenteric artery, and portal confluence, and it was determined unresectable. He underwent adjuvant chemotherapy and radiation therapy. Subsequently, he was enrolled in EUS RFA study and underwent 2 sessions of EUS RFA 4 weeks apart. This is the initial imaging showing involvement of portal confluence. In these images, you can see involvement of celiac axis as well as abutment of superior mesenteric artery. Now, these images are after EUS RFA, and now you can see complete opening of portal vein and superior mesenteric vein and reduction in tumor size in this area. This is an MRI image after completion of 2 cycles of EUS RFA, and that shows no tumor involvement of celiac, superior mesenteric artery, or superior mesenteric vein. This patient was deemed as resectable, and he underwent successful Whipple surgery by my colleague Dr. Curtis Ray, who is panelist with us today. At UT Health, currently we are doing a phase 2 clinical trial. We are planning to enroll 10 patients with borderline resectable and locally advanced pancreatic cancer. These patients will undergo neoadjuvant therapy along with EUS RFA using EUS RA, and our primary endpoint again is procedure safety in this patient group, and secondary endpoint is overall survival and ability to do R0 resection. This is image of our Texas Medical Center, which happens to be one of the largest medical center, and I'm happy to share some of our live procedure cases of EUS RFA from our ongoing clinical trial currently. Our first patient is 78-year-old man with history of neuroendocrine tumor at tail of the pancreas. He underwent distal pancreatectomy with splenectomy 4 years ago. He recently presented with a recurrence of tumor at a distal body of the pancreas at site of prior surgical resection. Patient also has multiple other medical problems, and he wanted to try non-surgical options first before considering repeat surgery. Patient was started on lanreotide and was enrolled in ongoing EUS RFA study at our center. These are the US images of the mass at a distal body of the pancreas at site of surgical resection. This mass measures about 18 millimeter times 25 millimeter in size. Here we are doing elastography of a pancreatic mass. As you can see in elastography, you are seeing a predominantly blue color at the location of the mass, and surrounding tissue has a predominantly green color. This suggests mass is very solid, which is typical of neuroendocrine tumor of pancreas. And now I'm measuring strain ratio. In order to measure strain ratio, you typically measure the strain of a pancreatic mass compared to surrounding pancreatic tissue or duodenal wall. Here you can see two white arrows showing areas where I'm comparing strain of a pancreatic mass against a surrounding pancreatic parenchyma. And here, if you can see, our value of strain ratio is 65, which typically suggests very hard tumor, again consistent with a neuroendocrine tumor of the pancreas. Normal pancreas has a strain ratio value less than 4. Pancreatic adenocarcinoma has strain ratio value ranging from 9 to 12, and neuroendocrine tumor are the tumor where you see typically very high strain ratio. Okay, so now we are going to start with the US RFA procedure. As you can see here, I have decided to use a 5mm tip catheter and has advanced the catheter inside the tumor. And now we are starting the radiofrequency ablation. You can see a nice tissue bubbling effect secondary to radiofrequency ablation. It is important to maintain good endoscopic visualization of catheter tip and zone of ablation. Typically, with 5mm catheter, you use 10 watts and about 10 to 15 seconds for ablation. I also always continue to keep my eye on impedance, and if impedance starts to go too high, you can stop ablation sooner than recommended 10 to 15 seconds. I like to start ablation at the top of the lesion without using any of the elevator action. So subsequently you can use fanning technique and use elevator to target the different areas of the tumor. So now I'm using elevator and I will target different area of the tumor, and we'll start same radiofrequency ablation process. As you can see here, we can nicely see tissue bubbling impact secondary to radiofrequency ablation. We typically like to keep about 3 to 5mm distance from the distal end of the tumor, given the overall zone of ablation secondary to RFA. And so by now we have done 2 cycles of RFA. And at this point you can bring your needle back and rescan and try to examine other areas that you can target easily by EUS RFA. So here I'm just scanning back and forth to examine another areas that can be targeted with the EUS RFA. And here now I will try to target the distalmost area of the tumor. So now I'm advancing the needle at the distalmost area of the tumor. I've kept about 3 to 5mm distance from the distal edge of the tumor. And now we will start radiofrequency ablation process. Since this is a 5mm catheter, after finishing first round of radiofrequency ablation, I will just pull the catheter back, still keeping inside the tumor, and we'll start another cycle of radiofrequency ablation. This is called ablation in line technique. By doing this, you just with one puncture, you can at least ablate 2 times within the tumor. And again, during each ablation, it is very critical that you should know the needle position well and have a good vision, endoscopic visualization. So for this tumor, I have done so far 4 RFA treatments, and overall ablation impacts looks good. As you can see, tumor is also close to main pancreatic duct, so you have to maintain some distance of radiofrequency ablation from main pancreatic duct.
That was a beautiful demonstration, Nirav. Much appreciated. So we'll go on to your second demonstration before we have a panel discussion.
This patient has a history of chronic pancreatitis, and he has eventually developed a pancreatic head mass. Previously, we did a US with FNA and also ERCP and place a biliary stent. You can see some of the acoustic shadowing secondary to biliary stent. And also you can see calcification within the mass at the head of the pancreas. Here you can also see abrupt cutoff of a main pancreatic duct at the level of the mass. And mass is abutting portal vein. So currently this patient is undergoing neoadjuvant chemotherapy. On imaging study, he does not have any liver or lymph node metastasis. So our hope is that with neoadjuvant chemotherapy and possibly with a radiofrequency ablation, we can successfully downgrade this tumor and take patient for successful Whipple surgery. Here, mass approximately measures close to 3 centimeter in size, and I'm planning to do ablation using a 1 centimeter size needle catheter, and we will do ablation in line technique. What that means is that you pass the RFA catheter deep to the distal end of the mass, start ablation, and continue ablation and you move the needle while ablation still continues. So by doing that, just with a 1 needle puncture, you can ablate close to 2 centimeter area of the tumor. So let me get my needle ready and we will start ablation. As you can see here, our needle is ready, and I'll first start targeting top end of the tumor, close to main pancreatic duct when there was abrupt cutoff. I typically try to keep at least a 5 millimeter distance from the blood vessel or from the main pancreatic duct. So here we have advanced catheter close to the distal end of the tumor, and we are careful to keep some distance between catheter and main portal vein. And now we are starting the ablation, and as you can see, there are very nice echogenic bubble that tells you that ablation is going really well. And as you start seeing good zone of ablation, and once impedance starts to increase, typically this is the time that I'll continue the ablation while withdrawing the needle, and this will allow ablation of a proximal end of the tumor close to the duodenal wall. And as you can see here, the second zone of ablation is created, targeting the top end of the tumor close to the duodenal wall. And we are keeping close eye on impedance, and now the ablation is stopped. Here you can see very nice 2 zones of ablation, which are marked by echogenic bubble at the rim and likely immediate areas of tissue necrosis within inside. Now we will use a fanning technique to target the deeper end of the tumor in a separate area. So here, now I'm just using elevator to target the deeper end of the tumor. And again, we'll start radiofrequency ablation. Typically, I ablate close to 20 seconds, or we follow the impedance, and with a sudden rise in impedance, that would be the time. It tells you that ablation is likely complete, and you can stop the ablation and move the needle. Again, you can see nicely echogenic bubble, and I have removed the needle now. And now I will try the area of the tumor in between these two ablation, first and second, right in the middle of the tumor. And again, needle is placed, and right in the middle of the tumor, you can start seeing the echogenic bubble secondary to ablation. And so in this case, we did 4 cycles of ablation. Thank you very much.
Well, that was very, very instructive and very innovative. And we're all, of course, looking forward to your prospective trial. A couple of questions come to mind. I guess in terms of downstaging pancreatic adenocarcinoma for resection, clearly one of the contraindications is involvement of the major vessels. But your limitations with RFA is that you've got to stay at least 5 millimeters away from those vessels. So could you speculate a little bit as to how the RFA would downstage the vascular involvement?
Yeah, that's a good question. And this all stemmed from our initial experience that we did not expect truly to see true downstaging, but patient really wanted other choices, and we offered this choice, and patient was more than willing to undergo. This was about three and a half years ago. So that was like beginning days of EUS RFA with not much data. And to our surprise, that we did see a significant reduction. It was almost like a 50-60% reduction in a tumor size. So from 3 centimeter tumor become 1.5 centimeter in size. And that's when we saw that blood vessels, tumor was not abutting blood vessels anymore. There is good literature on RFA and immune activation in other organs, not necessarily in a pancreatic cancer. And the speculation here would be that it's not just a local tumor destruction, but maybe RFA also has something to do with local immune activation, and that's likely helping to reduce the tumor size. There is some animal data in pancreatic cancer, RFA and immune activation, but again, these are very, very early data, so hard to speculate that what is the exact mechanism.
No, very exciting. I guess not to play the part of doubting Thomas, but the beautiful images you showed of downstaging in the first presentation, you were showing post-RFA reduction in size, but those patients had also undergone neoadjuvant chemotherapy. I mean, did you compare the post-chemotherapy effect and isolate out the RFA effect when you looked at those?
Yeah, it's very hard because that study was truly looking at a safety. That is it safe procedure or not? Can you do it safely and you are not going to harm the patient? The study was really not designed, and we did not had not every patient had a standard chemo. Many of these patients were unresectable and well already on a 3rd or 4th round of therapy. Some of them were already on clinical trials which they had already failed. So this was like their 4th or 5th clinical trial. So based on that, it's very, very hard to truly understand. The patient where we showed that we could actually do the successful local surgery also had radiation, which is also we commonly use at our center. But that patient had a neoadjuvant treatment and radiation, did not have a significant reduction, and we mainly saw reduction after starting RFA. So that made us believe that there is definitely some impact of RFA.
Fantastic. Very, very exciting. Curtis, yeah.
I was just saying, I think, Dr. Fasani just presented a great talk, and so far, this EUS RFA is such an exciting new treatment. We know from plenty of experience that there are some pancreas cancer patients who respond well to just chemotherapy and have significant downsizing of their pancreatic cancers, and there are some patients who get chemo and radiation and have significant responses, and there are those who don't respond, and unfortunately about 20% of pancreas cancer patients progress on neoadjuvant treatment. And we really don't understand the genetic profile of those cancers that respond and those that progress. And I think even for this treatment, for EUS RFA, there's probably a genetic profile that will emerge for patients that respond really well to this. And that's the subset of patients who are really going to benefit from chemotherapy and RFA. And there's probably a subset of patients with a different genetic phenotype who are going to be resistant, progress, and not have the same outcome. And those are questions that we're not going to have the answer to for 5 to 10 years.
Right. Good. All right. Any other comments?
Dr. Tassani, so there's actually a question from the audience that was a question I was going to ask as well. So you have 2 specimens, I think, or 2 cases where you have resection results or pathology after the resection. Was there any specific observations in those resection specimens that was sort of instructed? Did you see any change in either immune infiltration or tumor histopathology?
Yeah, so we are still dissecting some of those data. One of the RFA specimen was fairly recent, and we have nice images from pathology to understand. But in general, answering the first question, that how much was downstaging and was there any vascular lymphatic invasion, this patient had a Whipple done almost a year and a half ago, and we did see extensive necrosis of a tumor, did not have any vascular or lymphatic invasion, and now it's over a year and a half since we have done it, and patient is still cancer free. So that was pretty encouraging. Again, that's 1 patient out of 10 of unresectable cancer that we had done so far.
Maybe one last question I have is regarding that strain ratio data. I have to say that in my anecdotal experience, adenocarcinoma tends to be much stiffer, harder than neuroendocrine tumors, and yet the strain ratio is reverse of what I would have expected. Now, the only explanation in my mind might be that the background pancreas with the adenocarcinomas that are being studied have more chronic pancreatitis and stiffness to begin with. But do you think that neuroendocrine tumors are harder when you puncture them? I know they have a rind sometimes, but I'm curious to hear what you think.
Yeah, and elastography data is all over the map. As you know, that it was pretty exciting 5-6 years ago, and I'd invested a lot of time and energy, but it's not that reproducible, to be honest with you. And I think it all depends on where you select your second zone to measure the strains. And I think early on, people made a mistake of measuring cancer against pancreatic tissue, and as you highlighted, that maybe in adenocarcinoma, rest of the pancreas, especially if there was a chronic pancreatitis and cancer, you are going to have a relatively higher stiffness of the tissue. So I think now, most recently, I've moved measuring the strain against duodenal wall. With that, there is at least a little bit more reproducible data. And again, neuroendocrine tumors, I have seen both ways. Published literature suggests that neuroendocrine tumor has much higher strain, but same as you said, many times even in adenocarcinoma, I have seen very, very high strain ratio, and neuroendocrine tumor I have seen less. So I go by color elastography, but not much with strain ratio values.
Okay, well that's very helpful. So All right, I think we'll move on now. Let's get, we're looking forward to the surgical perspective. And Curtis, we're very happy to go forward with your presentation.
Thank you for having me. So again, I want to thank Taiwan Medical for the opportunity to participate in this exciting webinar. And we'll talk about surgery for pancreatic cancer and how does EUS RFA play a role in the management of these patients. Next slide. So we all know, everybody on this call is probably very familiar with all too familiar with the pancreas anatomy, and what makes surgical management and treatment of this disease so difficult is the relative location, as many of the speakers before me, Dr. Haber, have said. Two large tumors, a 3 to 3.5 to 4 centimeter pancreatic head cancer, anatomically is difficult to manage. You have the common hepatic artery, celiac axis, superior mesenteric artery, gastroduodenal artery, inferior vena cava, a lot of really critical structures to the abdominal mesentery and viscera, all are intimately associated with the pancreas, and surgical management is very difficult. And anything that we can do to try to make the operation easier and safer is desperately needed, and what clinicians have sought for the past 30 years. Next slide.
Do you have that slide? Curtis? Sorry. Nirav, can you hear me?
Yeah, I can see the slide. Yeah, I can hear you. I can see the slide. I'm not sure, Curtis. Somehow his screen appears frozen.
Yeah, I think maybe we lost his internet connectivity. I'm not sure, Nirav, if you want to, as a colleague of Curtis, and perhaps you want to take the lead and read the slide, and then Curtis will join us from his telephone or whenever we can get him connected back.
Okay, I think
sure,
I'm back.
I mean, I can read it off
right.
here. Pancreatic cancer 2021. 60,000.
He's back.
Oh, good.
I think I'm back now.
Good. Welcome.
I guess that's one of the challenges of the virtual meeting. So, for pancreas cancer in 2021, the American Cancer Society in the United States estimates that there'll be 60,000 new cases. In contrast, when I was a surgical resident, that number was in the mid 20,000s, and 48,000 of those patients will die. And what's really disappointing is that if you think about some of the other cancers and the relation to some of these other cancers, mortality for pancreas cancer has really been unchanged for the past 20 years. In this graph, you can see how the mortality for lung cancer has decreased, breast, colorectal cancer has all decreased. But if you look at that line for pancreas cancer, it's stayed flat for a long time, and that's very disappointing. Next slide. And then survival. So in those patients that are surgical candidates, the 20% of patients when they present with pancreas cancer, roughly 20% are actually surgical candidates. Those who undergo surgery with chemotherapy, those responses are, and the survivals can be, pretty dismal. Stage 1A, only a 40%, 5-year survival. And those that are more advanced stage with node positive disease, less than 10% survival for stage 3 disease. Again, dismal results for this disease process. Next slide, please. So ultimately, when we think about, well, who is eligible for surgical resection? Again, only about 20% of patients are eligible, but those with localized disease, meaning they have no evidence of distant metastasis, no significant involvement of the superior mesenteric artery or major celiac vessels, no thrombus in the superior mesenteric vein, portal vein confluence. And in those patients, for the past 30 years, clinicians have really had in their toolbox to treat this disease: surgery, chemotherapy, or radiation. And typically it's been a combination of these three treatments that's really been our mainstay treatments. So what about now with this new additional treatment of endoscopic ultrasound guided radiofrequency ablation? Is that potentially a new and exciting fourth treatment that we can use in this disease process? Next slide. So essentially, nowadays for patients with pancreatic cancer in most academic medical centers, preoperative treatment or neoadjuvant chemotherapy is pretty much a mainstay. And patients that are high risk for positive margin, we know are not good candidates for upfront resection. We know that if a patient undergoes resection and has a microscopically positive margin, the effect is as if no surgery was provided. A debulking operation for pancreas cancer provides no beneficial treatment effect. Preoperative treatment may help to sterilize the surgical field. It may help to increase our rate of margin negative resections, may make the operation easier and result in decreased complications. Again, a standard Whipple operation has probably a 30 to 40% complication rate, and preoperative treatment and decreasing complications may prevent a treatment delay for those prescribed adjuvant chemotherapy. So these are all reasons why more effective preoperative treatment is interesting and exciting and necessary. Next slide. So for those with a resectable tumor, a small pancreatic head mass not involving the superior mesenteric artery or superior mesenteric vein, so somebody that we would say has a resectable tumor. So SMV and SMA are free from tumor, and really for this patient, what is the optimal treatment? In this particular patient, this was an older female, relatively healthy, but in her, actually this patient was in her 80s. And we were unsure really about how she would tolerate chemotherapy, how she would tolerate even surgery. So we started her out in this study at UT Health, where after diagnosis, she was started on systemic chemotherapy back in June of 2020. After several cycles of chemotherapy in late August of 2020, Dr. Thasani performed endoscopic RFA treatment to the primary tumor. I think after that, she had an additional 1 or 2 cycles of chemotherapy, and then underwent Whipple resection, pancreatic duodenectomy, in late October of 2020. Had a fairly nice response with T2N0 stage 2 pancreas cancer. Tolerated all of the treatments well, no complications, and was discharged from the hospital in a week. And this was a patient in her 80s. Not the most robust patient, but she tolerated all of this treatment. Next slide. So then, as was alluded to earlier by Dr. Thasani, what about the patient who presents with not necessarily upfront resectable disease? So this is a patient who has doesn't necessarily appear that the SMV is involved, but clearly in this case the superior mesenteric artery has less than 180 degrees contact with the tumor. So this would meet the definition for borderline resectable disease. And this is a very, very tricky patient to manage. In virtually all of these cases, upfront chemotherapy and potentially upfront chemoradiation is suggested by most surgeons, radiation oncologists, and medical oncologists. But in this particular case, what about, is there a role for endoscopic RFA? With this new novel treatment, is it possible, we could all hypothesize that maybe we see a increased response and a better downstaging of tumors? We know from plenty of data that the response rate for these types of lesions with standard FOLFIRINOX and radiation, that roughly a third of patients are able to successfully undergo resection. But Hopefully, is it possible that with the addition of RFA that we may be able to increase that number and increase the number of patients that can undergo margin negative procedure? I think only clinical trials will answer this question. Next slide. So currently, we're in the process of with two different trials. Dr. Thasani mentioned the one for borderline resectable and locally advanced disease. The one that's also become much more of a hot topic of late is those patients with upfront resectable disease. Is there a role for EUS RFA? And if so, how do we best study this in the context of a clinical trial? So we're currently in the process of accruing patients into this study, where following the diagnosis of pancreatic cancer, patients would receive either 2 doses of upfront modified FOLFIRINOX or three doses of gemcitabine and nab-paclitaxel or Abraxane. Following the initiation of the chemotherapy, patients then undergo 3 cycles of EUS RFA for a total of 4 months of upfront chemotherapy and ablation, followed by restaging with the decision at that point for surgical resection. Next slide. And at this point, again, I'd say that I think it's important to mention that all of these cases of pancreatic cancer at UT Health, as in many other places, are really best discussed at a multidisciplinary board with our interventional gastroenterologist, medical oncology, radiation oncology, and surgery to really determine the best consensus treatment. Thank you.
Thanks very much, Curtis. That was a very sobering but very realistic and honest assessment of where we are with pancreatic cancer management today. I think we could go to our Q&A session. So we will open up the discussion to our panel. There we go. All right. Hello, everybody. Now we'll move over to the question and answers, and let's see what we have. There are no open questions now, but if anybody has any questions, please feel free to speak. Let's see, here's a question here from Feng Ting Pong. Upon applying RFA to downstage the tumor before Whipple, where do you target, is the question. And after downstaging the tumor, are there any vessels like the superior mesenteric artery or portal vein that require reconstruction? So it's kind of a wide open question. I think, Curtis, you were going to address this question of vascular resection and reconstruction. Maybe you want to speak to that. Is there any difficulty with that? Let's say, does RFA impede vascular reconstruction, or does it cause damage to the intima of the arteries, that sort of thing?
Well, I think fabulous question. And one of the things that I was really most concerned about in the cases that we've done is there a chance that the RFA could induce fibrosis and potentially make the operation more difficult or unresectable? But to date, we haven't really seen that in the few cases that we've done, and we have a few more patients currently in the process of getting the chemotherapy and the RFA, and hopefully surgery in the next 2 months. So that will, because we're learning as we go. We're so new and early into this process. But we know that pancreas cancer has a very dense stroma, and I think that's what makes the chemotherapy so difficult to penetrate into the tumor and see that response. And is it the actual ablation of the tumor, the physical destruction, or is it a combination of that plus hopefully making the tumor more porous so that chemotherapy can penetrate into this previously impenetrable lesion so that we see a response? Again, all of these are questions that will take us 5 to 10 years to figure out, and I think you just need exciting and investigators who are willing to spend the time and ask these questions.
Sure. Tomas, maybe I could ask you, we didn't have any presentation of any cystic lesions, although you had that as part of your presentation. And of course, the experience that was recently published on serous cystadenoma. But let's address cystic lesions. Could you create a scenario of the ideal cystic lesion, let's say in an inoperable patient, that we might want to start with RFA as a trial to see if it would be effective?
Yeah, that is an excellent question. I think I think you can go from two ends of the spectrum. So you can I think the for the low risk lesions or potentially those that are at least meet, let's say, worrisome criteria only by size, these would be lesions where you really would want a study context where I think you can prove very high safety profile. I think outside of a study, to me, the ideal patient is somebody who is a relatively difficult sort of otherwise operative candidate with a cystic lesion that has a worrisome feature and perhaps some degree of slight neural nodularity, where I think you really might be able to offer sort of an early curative kind of treatment. So I have not done this, and I'm not aware of you really, again, other than what I presented of published literature on the cystic lesions. But I think my goal is to, hopefully in the next years to come, we will have a study to really address the hopefully high safety profile of this technology in low risk lesions. And I think for now, in terms of off study, I would probably target patients who are a little bit more on the high risk cyst, high risk patient kind of profile.
I mean, that would make a lot of sense. Taking something, a patient who's not an operative candidate, but has a high risk lesion, then clearly this would be an opportune time to try this technology. I guess, Nirav, I'd like to ask you.
I think that's a great point.
Noticed on that last clinical video that you showed, it looked like that lesion was very close to the duodenal wall. And on your last treatment, it looked to me like when you saw the cloudy appearance approaching the duodenal wall, you shut it off instantly. Could I ask you, have you seen any edema, erythema, any effect on the duodenal wall when you've had a lesion, which has been, let's say, within 5 millimeters or so?
Yeah, that's an excellent observation, and that's exactly what happened during the case. And as I started seeing that zone of ablation coming very close to the duodenal wall, that's when I stopped the ablation. I typically go back and put a upper endoscope back in just to check it. And our current protocol dictates that all this patient comes back for second round of RFA in about 4 weeks. So we had luxury to even re-examine that. So far now into 20 plus procedures, we haven't seen any significant duodenal injury or edema secondary to that, including this case. So sometimes just RFA puncture related minor bleeding you may see in the duodenal wall, very similar to USFNA, but haven't seen any long-term issues or complications to the date.
And then I was going to ask you, when you're treating massive tumors, inoperable patients, let's say for debulking effect, I noticed from your slides some very long duration of treatment. I'm assuming that was an aggregate of the total number of punctures. But let's say you want to maximize, the effect. Would you just tell me what's your max dosage and max size needle until you hit the 800 ohm? Let's put it that way.
Yeah, so that's a great question, and so far my max is up to 8 cycles of RFA ablation with a 1 centimeter size catheter. So that if you theoretically, it's still a sizable zones of ablation, close to 8 centimeter zone of ablation. And I haven't gone more than 8 cycles of ablation in a single duration. I do bring this patient back in 4 weeks and see typically those patients who have completed 3 cycles of RFA, I've seen during second time also there are viable tumor areas where you can actually target, but by third time, more than often you just encounter extensive areas of necrosis, and becomes very hard to truly know that where, if there is any viable tumor in this area and which is the best place to target.
Right, right.
Now looking at a Korean investigators and investigator from Indonesia who also use the US RFA, they have gone up to 10 cycles of RFA, and that's actually some of them typically do up to 8 to 10 cycles of RFA, and their safety data is also pretty good. That so far no major safety events, even up to going up to 10 times.
Okay, good. Any other
There's
comments?
there's actually a question in the chat which I think would be interesting to pose to both Dr. Tasani and Dr. Ray, and in terms of opinion, how you feel this compares to electroporation and SBRT as alternative ablative strategies.
Well, I think, IRE, or the irreversible electroporation, has been out a little bit longer, so there's more data. It's a little bit more difficult, I think, a little bit trickier to administer. One of the advantages here is that I'm such a lucky person to be able to work with accomplished endoscopist like Dr. Thasani, because he can do this, and so far it's been really, really safe. We've had a few patients who've had a little bit of abdominal pain, but no serious side effects. If you look at any of the IRE literature, there are some pretty significant side effects and stories of massive bleeding and fistulas. And I think the modality of delivery for IRE, I think, is what's really been a limitation there. So I think what we'll see over the next couple of years is that, IRE just still really hasn't taken off, because it's just not that easy to administer to patients.
Yeah, I think I would agree with that. I would just interject that there's a really beautiful article by the Dutch group that studied IRE, where they put on the same graph sort of survivals and number of patients treated with radiofrequency ablation, IRE, and SBRT. And the RFA experience there is primarily surgically delivered or percutaneous interventional radiology delivered RFA, not endoscopic ultrasound. But at least on that graph, the 3 modalities are not terribly different. But if you look, I agree. If you look at the IRE studies, the adverse event, grade 3-4 adverse events in some of those studies are upwards, in some upwards of 20%. So that's a very significant concern. I think the IRE data is strong in response, but is also somewhat concerning in safety.
Well, I don't think are there any other. I don't see any other questions, and I think we've had a very, very educational seminar. I really want to thank Dr. Gonda, Dr. Stasani, Dr. Ray for contributing all of their experience on this novel technique, which is now taking hold, and now we can see sort of the range of applications for RFA and the relative safety with this technology. So we are very appreciative to Tai Wung for sponsoring this, and of course to Endoscopy Now for providing a platform for educating our colleagues. So we look forward to a 1-year follow-up. Let's see what's happened after another year of experience, but this is very exciting, and I think that our audience will take away a lot of information from this. Thank you to everyone.
Thank you.
Thank you.